Hello, everybody. I'm Valarie Worthy, and I'm really excited about presenting to you our patient navigation model. And I'm going to just do a little background history about navigation. But I wanted to tell you that no matter what cancer center you go to, that navigation will look different in each one of those centers because most cancer centers, I would say, target their navigation program to where they are, the individuals that they service. And so I call that targeted patient navigation. And so I'm going to walk through what we do at Duke and how we arrived at our model. You can turn now, Christy. Okay, just a little background. Patient navigation started like early 1990s. Harold Freeman, Dr. Harold Freeman is a breast surgeon, and what he noticed was that a lot of his patients who were in the inner city of Harlem would present with late stage diagnoses of breast cancer. And so he thought maybe if he provided interventions out in the community, such as people getting screened sooner, that maybe then they would present with early stage breast cancer as opposed to later stage breast cancer. Next slide. So he continued on with his program. They did find out that when you go out into community, you connect people with screenings, and those were mammographies, that the outcomes were much better. From his intervention of what we call outreach navigation, he began a training program, and that program has been going on for years now. And many navigators, including me, have been involved with the navigation program and his training. And I just encourage people, if they possibly can, well, I know it's COVID season now, but if you can, this navigation program is really great. And you also get an opportunity to go into his center, talk to survivors, talk to navigators. So it's a really, really good program. Next slide, please. So when you're looking at oncology navigation, the continuum of care, we at Duke look at prevention through end of life. So when I talk about prevention, we have community-facing navigators, and those navigators are the ones that are out in the community, encouraging people to exercise, follow a diet, minimize your alcohol use, tobacco cessation, and we also connect them with our tobacco cessation program. Moving on towards screening, the outreach navigators also encourage people to get their pap smears, their colonoscomies, for men to get their PSAs. So these are the kind of things that our outreach navigators do. As we move on to diagnosis, and that's when our clinical navigators, non-clinical navigators get involved with the patient. So this is from diagnosis to end of life, or to survivorship, end of life. In all of the different elements from prevention to end of life, we're always assessing patients, attempting to eliminate barriers. And then if these patients need any type of supportive care, the navigators are also connecting the patients and their family to needed resources. Next slide, please. So identifying a model. How do we begin identifying a model in the continuum of care? So we looked at prevention. Next click. We looked at the screening piece, which I discussed, our diagnosis, treatment, and survivorship. And so at Duke, in our inpatient setting, we focused on looking at next click. We focus on looking at diagnosis, treatment, and survivorship. So those are the things that we focus on in the cancer center. Next slide, please. So when we're looking at our program, what's important to patients, what's important to family members? Care coordination. And what that means is that the navigator is that glue that brings all of the pieces together. She is the one that helps the patient throughout their continuum of care. And so we understood that care coordination, no matter where it is, out in the community or in our cancer center, is very important for us to begin at that point. Also, provider communication. Oftentimes patients don't understand their diagnosis and all that is involved in their care. So we provide education not only to our patients, but sometimes to our providers, so that they understand what their community setting looks like. When this patient goes back out in the community, are they going to be in a food desert? How close are they to a pharmacy? How close they are to a bus line if they don't have transportation? And of course, patient education is just key. I believe that knowledge is power. And when we begin to teach our patients about their diagnosis, side effects to medication, then they can have a conversation, an informed conversation with their physician, and also patient family advocacy. We're always advocates for our patients. For example, if we had a patient that had 3 appointments on 3 different days and they lived 3 hours away, of course, we would try to work really hard to make sure that we can get all of those appointments on one day. Sometimes patients don't understand that we do have that kind of flexibility. So as navigators, we are always advocating for our patients. Next slide. Next slide. Thank you. So these are just some definitions and functions of each one of those roles for care coordination, provider communication, patient education, and patient family advocacy. And you just can kind of look over those briefly. Oh, you're good. Next slide. So when we're looking at our program and how do we get it started and how many people are actually involved in navigation, even though they may not be called navigators, we had to look at our NPC as our new patient coordinator, our clinical navigator, our clinical nurse, our triage nurse, our medical social worker, and our non-clinical navigator. All of these different people do different things to get our patients to and through their care. So when we look at our new patient coordinator, for the most part, that is the first patient, that is the first person that our patients talk to. For the most part, they never see them, but they talk to them. So they're the ones that are making sure that they know when their first appointment is, they're getting all of their paperwork together, all of their x-rays together. Then for the clinical nurse, she's probably the first person, along with the clinical navigator, that sees the patient when they come into our clinic. So we make sure that as a clinical navigator, all of those different touch points. So you'll see here, clinical navigator doing diagnosis, treatment, and end of treatment. We found out, and research suggests that these are some of the critical times that patients are nervous and have a high distress level. So we want to make sure that at every stop that patient is assessed using our distress screen tool, so that we'll know then, do they need other services, supportive care, those kinds of things. As the clinic nurse, although she's not a navigator, she provides education about the disease, about treatment, when to call if you have questions, along with our triage nurse. So each one of the patients that go through treatment are also given the number for the triage nurse. If they would, for example, have treatment one day and then that evening they would have side effects, and they know to contact the triage nurse as well. Navigators and medical social workers work hand in hand. Oftentimes our medical social workers focus on insurance and helping patients with disability forms, and then oftentimes they will then give the referral back to the non-clinical navigator to provide those what we call concrete services, transportation, assistance with co-pays, housing, those kinds of things. So it takes, I would say, a village, I'll call it a clinic village, really to bring navigation to fruition and for us all to work together. Christy? So when you look at this, it's kind of like an umbrella. We look at our clinical nurse, our triage nurse, our licensed social worker, and our new patient coordinators. We look at all of those different services, and our hope is that everyone works in concert, but that we don't have an overlap. The goal is that everyone works at the top of their skill set, and then we can all work together to have great outcomes for our patients. Next. So the little caption at the end is, each team member involved in the patient journey plays a critical role, and that we want to make sure that our roles are delineated and there's no duplication. Christy? So when we look at our navigation model. Each disease group in our plan would have a non-clinical and a clinical navigator. So there are oftentimes when both of the navigator, non-clinical and clinical, will be working with the one patient. The clinical navigator is a navigator that will stay with the patient across the continuum of care. The non-clinical navigator will address, as I said earlier, all of those concrete barriers. And then once they are eliminated, the clinical navigator stays with that patient throughout their care into survivorship. Next. So these are just examples of a patient that is eligible for navigation. And when I say that, that means that a patient has a barrier, they have a concern, they're distressed about their disease, their family member is not handling the diagnosis well. So that person would need a navigator to connect them to other services. And again, I outlined earlier our non-clinical navigator role and our clinical navigator role. Christy? So here we go, our longitudinal patient navigation matrix model. And so thanks to Dr. Paterno and Dr. Corbett, they worked together to have a wonderful model. But as I was building up to this, I wanted to show you how many different disciplines and people are involved in this care for it to come to fruition. And so to your left, if you look at community navigation, they play a critical part in identifying pockets in certain communities that really need education, assistance with screenings, transportation to get to these kinds of screenings. And then oftentimes there is a handoff to the navigator once this person comes in, gets a screening, and is diagnosed with a cancer. And once they come in, then again, as I said earlier, they will meet the new patient coordinator, a non-clinical navigator, and a navigator. And as I said earlier, the clinical navigator stays with that patient throughout the care. Now, as that patient experiences their treatment and other things, all the services that you see at the lower half of the square, services to meet identified needs, we have so many different services. And I'm so proud to be a part of a cancer center that offers this. I'm a 21-year breast cancer survivor, and I was treated at Duke. And so I know how Duke has grown in terms of meeting the needs of our patients. And so when you look at our medical family therapists, our social worker, our nutrition, self-image, I mean, there are so many things that will help support our patient during this scary time. We also, to the left of the new patient coordinator box, is our distress screening tool. And we ask that patients complete that because that gives us a window into what they are dealing with. And oftentimes, patients select these, just like a little questionnaire, they select these, and from that, we know what referrals to make to whatever different group that can really help them with the needs that they have. Our distress screening tool is administered almost at every visit. And we look at that very carefully to see if there are certain patients that have certain concerns so that we can anticipate the needs that patient may have even before it is exhibited. And as you see the little, go back just one second, I'm sorry. If you see the little arrows, this is a continuous process. It just doesn't start and stop and not go back. Whenever we need to, let's say for example, we have a patient that comes in and we notice different zip codes, and I'll just throw out 27701. If we have a lot of patients that are in that zip code, what I do as a navigator, I will talk to our community-facing navigators and they'll say, you know, we're getting a lot of patients out of that 27701 zip code. Is there some type of education that you could provide for people in that community that will help them get to and through our cancer center and make sure that they get screened properly? Okay, Christy. So the benefits of patient navigation, of course, our clinical outcomes. If we can help a patient at every touch point, we can identify needs and make sure they're connected to the proper resource. I believe that it's a smooth transition from, for example, surgery to chemotherapy to radiation. We tend to keep more of our patients. Of course, there's a downstream revenue from that. And then we follow up with our patients. So, for example, if a patient has completed their treatment and they have like a 3-month follow-up, we make sure that we call them a couple of weeks, if not a month before, to make sure that there are no barriers. For example, if they have problems with transportation, we ensure that we have connected them to someone that can provide that service for them. So all of these different factors, I think, contribute to the benefits of patient navigation. Next slide. So again, whenever you're doing a program, you always want to make sure that you have metrics and that you can show that your outcomes are really measurable. And so I'm not going to read all of these, but just these are a few things that we decided that were important when we began the program. So how many referrals, where were those referrals sent to, who did we get referrals from? Did the patients that we navigated, did they adhere to their treatment? And also, hopefully, in doing all of this, that we decrease our no-show rates. And then to your right, we have the long-term outcome measures. And again, that's the no-show rates. And when we're doing our work, is this minimizing some of the emergency room department visits? So we hope that in doing this, and I think for our short time, we've discovered that navigation does make a difference. Okay, Christy. I think got a couple of more slides. And this was kind of like just our navigation process, how we all got together, planned it, worked together, and also did our pilot for our teen and young adult. And I think there's a breakout session on that. And then after we get the data, then this will help inform us on then how do we look at other disease groups. Next. And then for me as a patient navigator, I'll look at our data. I'll administer, we have an assessment for each disease group to see what type of navigation works for them. And then we'll recommend the navigation services that that disease group needs. Next. And so our take-home message is that no patient that comes to Duke Cancer Center should feel alone. We have enough services and people that really care to provide these services. So when you walk in, you are embraced. We want to walk with you through this journey, so you're never alone.